Good evening, everyone. My name is Shannon Walls, Library Director at Silver Bay Public Library, and I am grateful for this opportunity to talk to Logan from Ecumen Hospice, a social worker there, about hospice and some myths and misconceptions people have about it and how it can really enhance people's lives. And so, without further ado, I'll turn it over to you, Logan.
Thank you. Thank you, Shannon. I appreciate this opportunity. So tonight, kind of the objectives, identifying, like you said, those misconceptions regarding hospice, defining what hospice is, describing the benefits with that, and kind of reviewing who are the core members of the hospice team, and maybe lists of eligibility requirements and how to begin the process of hospice. So I will be
Sounds
just
great.
referring to I will
Yeah.
be referring to my notes here, and feel free to ask any questions as they come along. So what is hospice? We say it is a special type of care for someone that is determined to have a terminal illness. Really what hospice provides for that person, making it special, right, is we focus on the person as a whole, with the holistic approach and taking that into our treatment. So treating their physical needs, their emotional needs, and their spiritual needs. Let's see here. So kind of the facts that, just regarding the dying process, many people, like I'm sure you and I, hope to die in their sleep, right? That is the envision. We want to
Right.
die peacefully. However, 7 out of 10 Americans do die from a chronic illness or a terminal diagnosis. 133 million Americans actually do have a chronic disease or a terminal illness,
Quite
which is
high, isn't it? Yeah, it's a lot of people.
yes, very much so. And I don't think, very well talked about, which we'll discuss later on too. But just in rural Minnesota alone, 75% of those deaths occur in the hospital setting, versus at home or at a facility. So just thinking of that percentage too, I believe is, pretty high. Another fact is that, we have these surveys, and one of those is that majority of the people, 96% actually, said that they wish they would have started hospice sooner than later.
Yeah.
So something to consider as we kind of go along today.
And maybe you'll cover this, but I'm just curious. You said,
Yeah.
75% die in a hospital. Would all of those cases be, in general, something that could have maybe transitioned to a hospice care setting, unless it was like a sudden unexpected death?
Right. We can't predict the sudden
Right.
unexpected, but definitely, starting that type of conversations of what are my treatment options sooner than later, and what does that person prefer? And maybe some of those are people that wanted to die in that hospital setting,
Yeah.
right?
Yeah.
Where maybe others wish that they could have at home, and that could have been prevented with maybe starting the conversation a little earlier and
Yeah.
seeing what the options were.
Yeah.
Absolutely.
Yep.
Yep. Let's see. One of the most common questions is it hospice for somebody with just cancer or, more of those relatively known terminal illnesses? So of course, that is a very common hospice diagnosis, but there are others to follow. Just to list a few, there's heart disease, COPD, Parkinson's, liver disease, kidney failure, Alzheimer's and dementia. That is big. Stroke, and one that isn't so common is adult failure to thrive or protein calorie malnutrition. People don't typically see those in the realm of being hospice appropriate, right? But especially with adult failure to thrive, maybe you notice yourself or your loved one don't have the desire to get out of bed any longer, or maybe the simplest daily tasks are now daunting, or they're getting more fatigued with even just dressing or bathing, or they're denying more meals. We consider that, we look at that as how can we support it, and how can we provide that care. So just something to consider. It doesn't have to be this cloud of, that terminal illness. It's, again, the whole person and those changes that everybody is noting.
Yeah, I would say that makes sense. Like my husband's grandmother passed away this late summer, but she had been on and off hospice for a number months, and
Mhm.
probably because of that failure to thrive, just because it was harder and harder for her to do things, and
Yeah,
anyways,
yeah.
it explains a lot, that to just note that, like, that's an option.
Yeah, oh, yeah, absolutely. Yep.
Mhm.
Um, Another thing with that is terminal illnesses aren't as openly discussed,
Yeah,
or some people go without knowing they even had one.
yeah,
We have had many of folk be shocked that they do, they are approved or they meet the requirements for hospice. And what does this mean? And of course, the word terminal, that is
yeah,
terrifying for any of us. It absolutely is. However, I think because it's not so openly discussed, I think that's just kind of our culture.
mhm,
We tend to kind of steer away from words like terminal, dying
yeah,
process, death itself. It's a very taboo topic. And hospice is a way to navigate that.
yeah,
Absolutely. Have
mhm,
those open conversations and make more people comfortable with it, whether
yeah,
who is in your circle. I do think as well the doctor training and just kind of the hospital like setting,
mhm,
they are definitely symptom focused, and that makes sense. Treating
yeah,
the symptom, getting better. Um, that's not everybody's goal, and we understand that. And so our big goal is to complete treatment with dignity.
yeah,
Um, and again, meeting that person, right, with that holistic approach. Um, I think terminal illness too, and somebody hearing that they do qualify, initially go to that the dying process has started
yeah,
immediately. So again, having those conversations and providing that education, that not here to make that process any quicker or initiate at day one,
yeah,
simply to meet you where you're at and make you comfortable. So,
mm, yeah,
yeah. Um, Another following that is everyone with a terminal diagnosis, terminal illness, do they automatically qualify? That is not always the case.
hmm,
Um, you do have to show certain indicators to prove 6 months or less is what insurance is looking for in order to be on hospice.
okay,
Um, and there's other steps with that too. The doctor, your physician, or a hospice physician does have to give the approval. Um, a patient and family kind of have the understanding that they no longer want to seek out that life sustaining treatment. So
yeah,
it's starting that conversation. Um, but another, what was I going to say? With the having the terminal diagnosis and no longer wanting the curative treatment, we have people who are full code on
mm,
hospice. They are saying we still want all life sustaining measures to occur in a hospital. We have
yeah,
still had folks sign on with that because you still have a choice, which we will get into. We review this, we initiate these discussions. It's just really, again, just knowing that you have options. I think
yeah,
that's the biggest thing with hospice is you have options. Have you talked about this before?
yep,
Yeah, yep, I think that. So with that, can a person change his or her mind once they're already on our services? Absolutely. We call it revocation of service. It is one simple signature to get off if you are saying, nope, this is no longer what I need. We have had a few, and it's a rare case, but we have had folks that maybe are with us for a month or two, and they decide that they would like to see their physician again. They would like to seek a certain treatment. Maybe it works out, maybe it doesn't, and they come back on the services. So even though you might revoke one day, we do not, you know, scare you away from ever coming back onto services. You are not punished for doing that. Again, all about options and giving those to those individuals at any given time in their treatment. Yep. There's also, transferring as well. So depending where a person is located or whether they prefer a hospice over another hospice company, we'll always have those discussions too. And then there is discharge or graduation of hospice. This is actually more common than revocation because I think all the extra attention, social visits, the kind of therapeutic interventions that hospice provides,
yeah,
patients tend to improve in their conditions. And now we can no longer make the argument that you qualify.
yeah.
We,
That's not something I
yeah,
would ever consider, right? Like, you think you just, who knew that was the thing that happened?
exactly. I
Yeah,
mean, you hear hospice, you automatically think end of life. you don't think potential to get better. Um, but yeah, we have many that have gained weight and all of a sudden they're up and eating, and one
Yeah.
even joined a gym class, and they just
Yeah.
start thriving. Yeah, so just something to consider. It's not the end all be all when it
Yeah.
comes to hospice. Um, with that, with the kind of extra attention and who's all on the team, we do have a slew of team members that would come and meet you where you are at. So that starts with our medical director, the
Mm-hmm.
physician. Each person then has their own primary case manager, their own primary nurse.
Mm-hmm.
Um, they would have their own hospice aide, social worker. We have chaplain and spiritual counseling,
Mm-hmm.
music therapy, massage therapy. We have companion volunteers. We have therapy dogs, hospice hounds is what they're
Yeah.
referred to. And we also have end of life doulas,
Mm.
which is a newer program, but
Yeah.
very interesting one.
Yeah.
Kind of like a birthing doula, just the other spectrum of life,
Yep.
and continuing to, assess those needs and what does that look like. So I will just kind of give a brief synopsis of what each discipline kind of does. Um, so the physician, they are the person there for regarding all medical questions, any decisions that kind of affect care, depending on where you are located, whether you need equipment, the medications, the care planning, perhaps there's other referrals to be made. So that is kind of a generalized physician that oversees all the care. The nurse, of course, is the one to carry out and coordinate that care.
Mm.
And really, the nurse's main focus is definitely pain and symptom management,
Okay.
um, kind of assessing the physical being and what's happening in that moment. And definitely education, right?
Mm-hmm.
They're the ones that are going there every week, minimal 2 times a week, or less, depending on what the family wants. But they're there to completely support you and educate you through every process step of the way. The social worker, definitely those psychosocial changes just due, I would say, to the challenges that come along with facing you do have this terminal illness, right? There's going to be all sorts of factors to that. So a social worker is definitely kind of the navigator through those, or even, reaching out for additional resources if needed, financial needs, any sort of end of life planning, advanced care planning, kind of what we do. Let's see, the aid, they're there for personal needs, personal cares, um, whether that's a bed bath or maybe a full shower, or some people just want a good old foot soaking, whatever that looks like for them in that moment, in that day. And then the spiritual support, understanding, their faith background or having no faith, but just being that person as kind of a source of hope and comfort, and being there for the family and caregivers as well. And then we have massage therapy. They support comfort and relaxation. It's shown to reduce an anxiety and stress, kind of that muscular tension, all sorts of benefits to massage therapy, really. And finally, music therapy, which has been shown to have the power to also alleviate pain. Um, Folks tend to engage in a lot of life review with music therapy. It kind of retrieves these memories. Maybe it's a wedding song or what have you. And it can be just provide this kind of shared experience with your loved ones as well. So
And that is like the music therapy is like something facilitated by is that like a license sure you can get or is it yeah.
yeah, so they're board certified
Yeah.
music therapists that we
Oh wow.
hire on our team. And yeah,
Huh.
absolutely. So they have, these therapeutic interventions and power of music that can bring everyone
Yeah.
together. So
Huh, that's
yeah.
cool.
Yeah, absolutely. So that is kind of just a general, just right now, before I kind of go into the misconceptions. Is there anything more you want more detail on, or?
Do you talk a little anything about like the costs or like how families do that? Is that gonna come up
Yep, I
soon?
will definitely get
Okay.
into that, kind of like the myths and the facts. Yep,
Yeah,
absolutely.
that sounds great.
Um, yeah, so starting with the misconceptions of hospice. First one, most common, is isn't hospice a place you go to die? I would say perhaps at one point it was. I have never known hospice to be that.
Mhm.
Um, it has definitely developed over the years. Again, that is getting the education, the training out, the hospitals understanding, the doctors understanding that hospice is most often provided in the place that you call home, and that is
Okay.
for your choosing.
Yep.
Um,
Hmm.
so we can meet people wherever. We have served in, of course, skilled nursing facilities, assisted living facilities. We have served in patients' own homes
Yep.
or their family homes, wherever to them is their home at that point. Um, and again, it is not signing on to hospice and, okay, the dying process has started.
Yep.
Hospice is not there to hasten that by any means. We are just there to meet your needs and hear your wishes.
Yep.
Um,
And do you have space for people who may not feel like they have a place to be or call their home space? Like, do you have facilities people can move to?
yeah, yep. So we're based out of our own facility here in Duluth, but that is immediately, the social worker and kind of the case manager's job at that time. What do they need? And of course, a home or, a roof over their head, somewhere that they need. That's going to be our number one goal. And that can also happen within hospice too. Maybe we do have a patient that just started and they are in their own home, but they don't feel safe. We're going to work on getting them somewhere where they do,
Okay.
based on their needs. So
Yep.
um, I think with that too, people hear, oh, okay, they come to me and, I'm on hospice, I'm at home or a facility. That
Yep.
does not mean that you have to be homebound. Um,
Mm.
we like to empower the idea of independence and quality
Yeah.
of life. So if you want to go to church or you're going to a movie on Friday with whomever, we're going to encourage that.
Okay. That's
Yeah,
yeah. Yeah. Yeah.
absolutely. Yep. We don't want you to stay there. We want you
You're
to
not
live
just
as
lying in a
well.
bed
Exactly.
for the whole
Exactly. That
time. Yeah.
quality of life piece we encourage throughout the whole process. Or maybe it is laying in bed. Maybe
Right. Right.
that is
That's
quality of life for you, right? I mean,
absolutely. But
where do
yeah.
we meet you? Yeah.
Right. Yeah. I do think
Yep.
there's like maybe at least I have this like stereotype of like, oh, you're like hooked, like you are in a bed and you're maybe hooked to some
Mhm.
machines at this point, but that's not necessarily always the case.
Yeah, yep. I think I've heard from people when I've asked, they envision a hospital-like setting, like a bright white room, a hospital
Yeah.
bed, and all these beeps and machines
Yeah.
going off, but it is completely opposite of
Yeah.
that. It truly is. Yep.
It's like very much reshaping people's images of what this experience could be like.
Yeah.
Yeah. Hmm.
Yep. Yep. And I've heard people say too, like it almost sounds too good to be true. And I think it's again just that lack of information that's out there of
Yeah.
what hospice really can be for somebody. Um, Another myth or misconception is they think that they can't keep their own doctor and that they
Hmm.
fully have to change their primary care over to hospice. That is not the case. You can always choose your primary care that you've had now to continue to follow you.
Yeah.
Yep. And how that looks, of course, orders will go through hospice, etc. But we are always coordinating with your doctor.
Yep.
Some folks believe that they can't continue to see their doctor. That is also not the case. You can still have your monthly check-ins with them. You can still go to a physical.
Yep.
You can still even consult with specialists for second opinions throughout the whole process.
Yeah.
The main factor is that hospice just needs to be kind of this first line of communication, again for insurance purpose. But we
Right.
would never, steer you away from seeking other medical opinions or to attend. Maybe it's an eye appointment or an ear appointment or
Yes.
whatever that looks like. We would never discourage you from doing that.
Hmm.
Um, One that we hear a lot is, don't hospice patients just get knocked out or sedated?
Hmm.
Um,
Yeah.
Yep, we do know there is a fine line between comfort and sedation. We are for comfort. We are not for sedating the patient. Again,
Yeah.
that quality of life piece is part of our philosophy.
Yep.
Um, of course, we do manage pain and symptoms with medication only as the patient or the decision maker for the patient, whoever is that person's advocate,
Yeah.
allows us to.
Okay.
Everything is always approved by you know, the family, the loved one, the patient. We're
Yep.
not just going to go in and give all these without permission.
Yep.
Um, only going to make recommendations. But yes, we do use pain medications as needed. And
Yeah.
if that makes the patient comfortable, then and they're okay with it, we're going to use it. Um, but pain and other symptoms can also be managed without pain medication. And those are the avenues we like to try, hence kind of our full team making this, interdisciplinary approach.
Yeah.
Maybe they're relieved by music and massage that day, and they
Yep.
actually, I don't need that Tylenol or I don't need that morphine in this moment.
Yep.
So taking every avenue before, reaching the bigger measures.
Yeah.
Um,
And
yeah.
that's stuff, I mean, I'm sure because a part of the team has proven to be effective, but do you have to
Mhm.
convince people of that sometimes, or is it just through the conversations, or like how do you that's like maybe not traditional thoughts again, like,
Yeah.
or like you said, this is a
Yeah.
misconception, but like how is that received?
Yeah. Yep. I think it's really displaying the right facts.
Yeah.
So we've had a few that at during time of admission, no, I don't need massage. No, I don't need music. I'm not used to that. I don't know
Yep.
what that would look like. Even for me personally, what would that mean? Is it just me and this one person sitting
Right.
there in this room? Um, so we don't push that at time. And I would never push it, but as I notice things developing, do I have that open conversation?
Yeah.
Do I give examples of, well, this one time or
Yeah.
whatever
Yep.
until they're kind of okay, maybe I will give it a try. And that's the thing, you can give music therapy a try and it may not be for you.
Right.
Okay, well, we know we tried that, thank you for trying that, let's try another avenue that is correct for you.
Yeah.
So
Yeah. That
mhm.
flexibility and
Yeah,
adaptation. Yeah.
absolutely, it's all about adapting to the person because not one is the same. We are constantly reviving our care plans. We meet every week to discuss each individual, what's working for them, what's not working for them.
Mhm.
Not one plan is going to fit every
Yeah.
patient. So
Yeah.
we understand that. Um, so kind of with those, um, where did I, sorry, my notes got all scattered here. So the truth about hospice is that, again, we are not here to hasten death. We
Yeah.
are also not here to prolong life.
Hmm.
Um, and I know saying that, can kind of get people a little angst. It's truly meeting you again, right there, right where you are, that present
Yeah.
moment, that present time.
Yep.
Um, the good and the bad days come for all of us, even now.
Yep.
We're all dying, right? We're all on this process of dying
Yep.
today. Um, so really just what does that look like for each
Yeah.
individual and understanding the uniqueness in each case. Again, we come to where that person lives, and that's all of us, and we are available to individuals 24/7. I know that can kind of be a little nerve wracking for folks as well that, you call us as the emergency services
Yeah.
and we come to you when you need us. And
Yep.
people go, oh, what if I need you at 2 in the morning? We're going to be
Give us
there
a
at 2 in the
call.
morning. Yes,
Yeah. Yeah.
exactly.
Yeah.
Exactly. Um, and there's different situations too with us being the emergency service. We've had folks that have had a fall that maybe led to a broken bone or,
Yep.
some sort of injury that was too severe for us to provide care to in that moment.
Yep.
We still want you to be treated. That is not part of your diagnosis, right? That's
Yeah.
an outside factor, and this is just where we're at now. So we would approve that hospital visit. Let's get you stabilized. Let's
Yep.
figure out a plan, and you can still remain on our services if you wish.
Yep.
Um, so just kind of with that too, like, of course, there's going to be these what if situations and kind of these outliers. We're going to assess those as they come and, do whatever you want to do in that moment. So.
Yeah. Hmm.
Mhm. Um, let's see. Keeping the preferred doctor, as I mentioned, hospice care is an addition to care already received. This is primarily for those that do live in facilities or communities.
Okay.
Um, so let's say you're already in an assisted living or a skilled nursing, they would still provide whatever you were getting prior to hospice care coming in. So we don't change. basically two separate parties. We're just that additional care to you, more attention, more eyes on you, those different things. So a lot of
Yeah.
times people think we come in to switch that care plan. No, whatever you were getting before, that stays intact.
Yep.
So again, hospice manages pain and symptom management. So we do have wound care consult nurse that we work with.
Mm-hmm.
So sometimes folks, that's part of their terminal illness is going to a wound care clinic to receive those orders, or going to the hospital to get
Yeah.
these weekly medications or what have you.
Right.
We then take that over, and you don't have to go to the clinic any longer. We consult with them and we just bring the orders and supplies to you.
Yeah. Wow. Yep.
Sometimes those repetitive appointments can be tiring, they can be
Yes.
daunting. And so some folks go, oh, I don't have to drive my car all the way,
Yes.
wherever.
Yes. For
I
this
don't have to go
appointment
every
and
Tuesday. Yep, exactly. So
yeah.
sometimes that's a relief for others. Another thing with that is that hospice is still able to promote, you know, those other avenues for pain management and for quality of life. We are still able to do certain physical therapy referrals.
Okay.
Maybe mom or dad's goal or whoever is to start walking again, or using their walker,
Yep.
or getting out of bed at a certain time. Let's assess that. Let's look at that. Let's do a physical therapy referral and see how we can better manage this right now.
Yeah.
Yeah. Um, there is little to no expense regarding hospice. So most cases, Medicare covers all of hospice as long as you
Okay.
have that Medicare Part A hospice benefit. However, some don't have Medicare. If you have medical assistance, that
Yep.
also covers hospice. And then other supplemental insurances or other additional insurances. If hospice is the route that you are seeking, they still have coverage majority of the time for up to 180 days.
Okay.
So almost
The 6 months. Yeah.
95% of the time, hospice is fully covered.
Yep.
And that covers all medications, all equipment that you may need,
Yep.
all the products that we supply. It covers everything. We always like to say you should never receive a bill from hospice.
Okay.
So,
Yeah.
yep. We do continue to support family and loved ones. If an individual is to pass on our services, we support family members up to 13 months.
Oh, wow.
Yeah, so that's following up, checking in. Do you need this additional bereavement? Are you open to grief support? How can we
Yeah.
help you? Um, and still, even then, I mean, hospice does a lot of community events and a lot of times of remembrance too.
Yeah.
Um,
Mm-hmm.
and that, I've even had folks who are on our services now go to those just for that kind of what is this? And,
Yeah.
starting that conversation again, just different
Yeah.
ways to become more open to it. I think the biggest truth about hospice is that hospice is not giving up. It is giving you a choice in your care and what you would like for your treatments, right? I
Yeah.
think it's an empowering experience
Mm-hmm.
versus not. I do not believe it is giving up whatsoever. So that's kind of knowing when to have the hospice conversation. Of course, you have to meet certain criteria. It is nerve-wracking to start that. It is nervous to either say to family or loved ones that you want it, or it is nervous for a family member or loved one to say to the individual, have you considered this? That is where we can come in prior and do things such as consultations to provide that early on education. Just because we're giving you the education does not mean you have to sign up with us, but that is absolutely always an option. Yeah. Any questions so far as we kind of wrap up here?
I think one thing that I thought about, and because it seems like hospice is a pretty relational process, and I'm just curious, can you just say like a little bit more about like what it looks like as like maybe not the patient that's in the hospice care, but that like what does it look like for family members or friends who are
Mhm.
engaging with hospice and the hospice workers, and how does it like, yeah, yeah, I
Yeah,
just like to know a little bit more about that. I think, or that's kind
yeah,
of something.
definitely. And I should have said too, when I was kind of reviewing who are the primary members of the hospice team, I normally always say the family members or the caregivers or
Yeah.
whoever you consider your circle, because you are constantly involved with that. And almost at every admission, we make it known you're just as part of this as they are, right?
Yep.
So, of course, like the symptom management is going to go towards the patient, but the psychosocial needs, we're going to include who that is, and that's
Yep.
the family or the caregiver or the friend or whomever.
Yep.
Um, and by that, it is constantly involving them as long as they are that safe designated person to share information to.
Yep.
So constantly keeping them updated. What would you like to see? What's going on today? How are you feeling?
Yep.
What are your thoughts towards all of this?
Yep.
Starting that from day one until the very end.
Yep.
Um, I think a big part of it is just building that trust of, again, we're not here to make the process go by any faster. We're here to work together.
Yeah.
And how can we make this be what you are looking for all
Yeah.
of you? Make it comfortable. I think that just comes with the education that comes along each step of the way. Um, just kind of being that comforting piece to them.
Yeah.
Mhm.
Last week we actually had a program around caregiver support. And so
Great.
do you have like one of the things we talked a lot about with the group was just the fact, like, what about like respite, or like does
Oh,
hospice provide some respite options for family members who might be
yeah.
assisting in the care?
Yep, it absolutely does. So if you are under Medicare, Medicare supplies 5 days of respite every billing period,
Yep.
um,
Oh, wow.
otherwise monthly,
Yeah.
almost monthly.
Yeah.
Um, Look at the certification period and what is the reasoning for this caregiver relief. That can be from multiple things. It could be for perhaps the caregiver is experiencing caregiver burnout. Of course, we want to assess that before that becomes
Yeah.
reality,
Yep.
but still giving that option. Or maybe there's a wedding they'd like to attend and they
Yeah.
just can't figure out how to get there or what have you. So, yes, of course, there's always caregiver respite. Same with veterans.
Yeah.
That is always nice to find out if somebody does have veteran benefits, or if they don't, would they like to start that enrollment process? Because if you are a vet, you also get the additional respite through the veteran benefits as well. So
Yep.
then you're kind of looking at 10 days.
Okay.
So that's always nice to look at
Yeah.
too. And we do the We Honor Veterans program, which
Okay.
does come with an additional thing with hospice as well. But aside from respite relief, there is also general inpatient care, which is
Hmm.
kind of what we talked about. If we are unable to maintain certain symptoms,
Yeah.
whether that is a injury from a severe fall, or maybe it's the patient cannot calm down. They're
Yeah.
experiencing restlessness, agitation, and the caregiver is unable to stabilize them as well. General inpatient, that gives the caregiver a little bit of relief and okay, they're being cared for.
Yeah.
So that's through, having contracts with hospitals and things. Or we do offer continuous care
Hmm.
too. And that typically happens more in a home type setting, but same situation. Terminal illness or restlessness and agitation is very common. Um,
Mm-hmm.
and it's absolutely hard to see. It's hard to deal with.
Yeah.
Even being a professional in this type of role, to see it and to be there.
Yeah.
So continuous care is where our hospice team is with you 24/7 throughout that process,
Okay.
not leaving the bedside. Yep,
Yeah.
absolutely.
Yeah.
And then, of course, we facilitate caregiver support groups as well.
Okay.
So there is all sorts of different um, ways for the caregiver to get what they're needing.
Okay, bro. And like, I think maybe this goes along with some misconceptions, or sometimes you think, like, as we talk, I like feel like, oh yeah, you like when you think of end of life, you're thinking about, or like my brain pictures elderly person. But
Mhm.
does hospice cover the entire lifespan of people who might need it?
Yep. So we are 18 and over. So
Okay.
if you are 18 years of age, you could qualify. If you are 110 years of age, you can qualify. So yes,
Yep.
18 and older. Yep.
Yep. And are there any hospice programs that help children?
There are, yep.
Yeah.
I believe it depends on the type of licensing you have.
Okay.
But that is more pediatric hospice type of care.
Yes.
So I work in the adult, but yes,
Yep.
there
But
are
families could seek support for a child. Yeah.
absolutely. Yeah,
Yeah. Yeah.
absolutely.
Yeah.
hmm Yeah, good question. Yeah. But I
So
don't really get, but I appreciate it. Yeah.
Um, another thing that I heard you say that made me just curious more is that you had said that, like when you're talking about no bills, but the equipment. Can you just talk a little bit about what maybe some common equipment that you have
Yeah.
available for patients that make their lives and their caregivers' lives easier that's available through hospice?
Yeah. Absolutely. I would say the most common wheelchair walker,
Yep.
right? That is kind of, we look at that right away. How are you moving around? What's best for you? Would you
Yep.
like to try this? It's called a Broda chair. That is
Okay.
very common too. It's almost like a hybrid of a really high back recliner and a wheelchair. And
Okay.
that just seems to be kind of a high priority list for our equipment.
Yeah.
And then, of course, a hospital bed,
Yeah.
any sort of lift.
Okay.
So perhaps that patient had a surgery recently and they're unable to get out of a chair on their own or get
Yeah.
out of bed on their own. We provide the lift to them.
Yep.
And with all of the equipment too comes that training too. We're not just going to throw this equipment at you and say, good luck, right? We're going
Yeah.
to make sure
Right.
you're comfortable with it. And, but I would say that is most likely the top, right? Just kind of, um, yeah, anything for mobility and just generalized comfort. So,
Yeah.
um, and our equipment, I mean, they move pretty quickly. So once we know that somebody is determined to need DME is how we refer to, maybe that is a hospital bed.
Yep.
Um, Typically, it comes within 24 to 48 hours. So
Yep.
once that's determined, we get it to them as quickly as possible.
Yep.
Yeah. Yeah. And in addition to equipment too, I mean, that goes for incontinent products.
Yeah.
I know people don't generally think of that being covered, but that is that's an expense. It really is.
Yeah.
They're
Yes.
not cheap products to have, and so we like to take that over and cover that, and that's
Yeah.
with wipes and gloves and briefs and creams and lotions and
Yeah.
powders, what have you.
Yeah. Oh, that's
Yeah.
great.
So
That's something
mhm.
you wouldn't even think of, but makes a big
No,
difference,
yeah,
right?
yeah,
Mhm.
yeah. It absolutely does. Yeah, yeah.
The other I mean, this is super helpful, and I really appreciate it, and I'm glad that we are able to, like, place this out there for our
Yep.
community to, like, see and learn about, and I think one of the things that I have, like, also experienced just, like, in, situations that, like, require medical care and comfort is just, can you name other, like or, like, how would someone learn more if they were like, "I just need more details," like, maybe it's calling
hmm
up a facility and asking questions, but
hmm
when you're trying to, like, learn how to advocate for yourself in these, end of care life situations, what might you turn to, like, have tools to, like, come in to the conversation, feeling like maybe
hmm
you hold a little more power or control that in a time when you don't feel like you have that?
Yeah, yeah, absolutely. I think, like you said, it's making that call. Do I want to know what my options are? Do I want to advocate for having more options?
Yep,
I know I have had just these generalized conversations with folks that maybe just called the hospital and said, I want to know what everything is that I can possibly have.
yes,
So then maybe they hear the word hospice and they go, well, who can I talk to? And then we have just gotten calls on our general kind of 24/7 line. They
yeah,
go, can I speak with somebody, whether that's in person or over the phone?
yep,
And then that's just sharing this material, which I do like. I like having those one-to-one kind of consultation,
yeah,
education moments because it's easier to be like, okay, I hear your situation a little bit. Here's how we could support it, or here's how we couldn't.
yep,
Just kind of personalizes that in the moment.
yep,
Um, so I would definitely say, of course, what I shared with you, I believe
yep,
on there is our 24/7. Anybody can use that to just say, we just want more information.
okay,
Um, or again, calling maybe your own primary and stating,
care
hey,
position,
yep,
yep,
exactly. Your own primary care, your doctor that you're comfortable with that maybe already knows you. I want more options. Is there somebody you can refer me to?
yes, yeah,
Yep.
that's great,
Yeah.
thank you. And
Yeah,
I'll include
absolutely.
those attachments with the show notes of this video
That
recording
would
so
be
people
great.
can
Yeah.
access those if they want more information.
Perfect. Perfect.
Mhm.
Anything else that I could give more detail to, or?
I thanks. No, I think that was super helpful. I appreciate you taking the time. And I'll just mention here that in a few weeks, we're gonna have an advanced care planning seminar
Mhm.
as well. So for folks who are interested in learning a little bit more about that process, we'll do a Zoom presentation and have the recording available for that too. So just good things to help you navigate situations that
Yeah.
you might find yourself in life, with grace and dignity and care
Mhm.
and community, I think, right? Yeah,
Yep, absolutely. Kind of
yeah,
the four things. If you don't mind if I leave you with a quote that I think just wraps up the hospice philosophy perfectly. So this is by Dame Cicely Saunders. The quote is, "You matter because of who you are. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also to live until you die." I think that just kind of sums up everything we discussed today. And
yeah,
thank you, Shannon, so much for this opportunity. I
yeah.
appreciate it.
That was a beautiful quote. Thanks for ending there.
Yeah.